I'm Dr. Jeremy London. I'm a board-certified cardiovascular surgeon, and I've been in clinical practice for the past 25 years. Today's episode is going to be centered around the diagnosis of heart disease. This is the third installment of a four-part series. We started with anatomy, the diseases of the heart, now the diagnosis, and we'll round out in the fourth segment with the treatment of these particular areas. Now, we've broken down the heart disease large category into basically three major components. And that's what we're going to center on today. The first one is blockages of the heart arteries, or coronary disease or cardiovascular disease, specifically centered on the heart. Number two is common problems that we see with the valves of the heart, or an architectural or structural problem with the heart valves themselves. And finally, with the abnormalities of the electrical system of the heart. And this is really how we have broken down both the anatomy as well as the diseases, and now consequently the diagnosis. The mission of our platform is to bring you easily digestible, relatable health, wellness, and medical information at zero cost. We would like to take a second to thank our sponsor, IM8. IM8 offers an all-in-one vitamin, mineral, prebiotic, probiotic, and postbiotic supplement powder. I personally pair IM8 with a well-balanced whole food diet to ensure I get the most foundationally sound nutrition. IM8's Daily Ultimate Essentials formula combines 92 nutrient-rich ingredients to help fuel your body with a wide range of vitamins, minerals, and micronutrients, building a solid foundation for daily health. IM8 has a science-backed formula that includes clinical dosages of CoQ10 to support heart health, and prebiotics, probiotics, and postbiotics to promote gut health. IM8 is third-party testing and NSF certified, guaranteeing that what you see on the label is what you get, so you know exactly what you're putting into your body. It tastes great, has no added artificial flavors, sugars, or sweeteners. If you're interested in trying IM8 for yourself, they're currently offering a free welcome kit plus 5 IM8 travel sachets with any new subscription and a 30-day money-back guarantee. Head to www.im8health.com/London and use code London at checkout for a discount. That's www.im8health.com/London and code London at checkout. Each one of these three categories is a very large topic in and of itself. What I've tried to do is center on the disease processes that I have seen most commonly over the last 25 years, and what you're most likely to encounter either with yourself, family, or friends. And so I felt that this would be an area that we need to focus on in each of these three main categories. In addition, please understand that each case is individualized and tailored to specific patients. So if you've been involved with yourself, family member, or friend, and I omit something that was done in a workup, or I mention something that wasn't done in a given workup, that doesn't mean that it was done incorrectly, because clearly I wasn't involved in that specific workup, and each patient offers different history, physical exam, and testing that may direct things in a different way. So don't let that work you up. Have a discussion with the physician. It's a relationship, and it's the physician's job to educate you, and it's your job to ask those questions. So before we get into each of these individual categories, I want to make some very general comments about making a diagnosis with patients and the process that we're taught as physicians. It's fairly straightforward, and it's really a standard protocol that most people follow. It involves a history, which is what's wrong with the patient or the chief complaint, a physical examination, then labs and testing, and finally making a diagnosis. Now, interestingly, of those different steps, I personally think that the patient history is typically the most important. And here's why. If you listen carefully, the vast majority of the time, patients will tell you what is wrong with them before you ever lay your hands on them, before you ever put a stethoscope on their chest, or before you ever get any lab testing or any kind of x-rays or invasive testing. Those things should be confirmatory of what you find from the history and consequent physical examination. So sitting down and talking to patients is absolutely paramount to understand what is going on with each individual. So let's start with the first category, which is blockages of the heart arteries or coronary artery disease. Remember that we have three basic areas of the heart: the front, the side, and the back. And each one of those has a specific blood supply that brings nutrients and and fresh blood and oxygen to the heart muscle itself. In other words, it's the fuel for the pump itself. Blockages of those arteries are what cause heart attacks, chest pain, and constitute coronary artery disease. So the question is, how do we figure out who has this and who doesn't have this? Well, essentially it's broken down into two categories, and that is patients that have symptoms, chest pain, shortness of breath, feeling like they're going to pass out, pain down the arms, palpitations, whatever it may be, and then totally asymptomatic patients, meaning absolutely no symptoms. And the workup for those is very different. We're going to start with the symptomatic group, only because I feel like this one is easy to connect the dots right away, because you know that there's a problem. They're coming in with a specific complaint. So again, we're going to start with the history. What's wrong? Well, the typical complaints are things like chest pain at rest, chest pain when patients exert themselves, shortness of breath when they exert themselves, palpitations, pain in the arm, nausea and vomiting, sweating. One of the big red flags, particularly for coronary disease, and when I say red flag, I mean it as a warning sign, is pain that is brought on with exertion and relieved with rest. I'm going to say that again. Pain or symptoms that are brought on when you exert yourself and then relieved with rest. And if you think about it, based on my earlier comments about what coronary artery disease actually is that if you have a fixed blockage in one of those arteries that's bringing nutrients and oxygen and fresh blood supply to the heart pump itself, at rest, there may be adequate fuel for the heart muscle to work. There's no warning signs there. But when someone gets up and climbs a set of stairs, or carries their trash outside, or goes to a mailbox that's far away from the house, and develops chest pain, shortness of breath, nausea, vomiting, palpitations, diaphoresis or sweating, this is where concern should begin, particularly if when they stop and they rest, the pain goes away, they exert themselves once again, and the symptoms return. Huge red flag for coronary artery disease. Now, obviously, asking about risk factors here is important in the history: high blood pressure, abnormal cholesterol, smoking, family history, and of course, obesity. Once you have a good idea as to what type of symptoms the patient has and what their potential risk factors are, then you go to the next category, which is physical examination. This should always begin with a set of vital signs, obviously. That looks at heart rate or pulse, blood pressure to see if there's hypertension, or high blood pressure, and pulse exams and blood pressure in both arms. Why is that important? Well, if you think about it, if someone has blockages in their heart arteries, they may in fact have blockages elsewhere and vice versa, because none of these things happen in a vacuum. We have arteries throughout our entire body. So hardening of the heart arteries can also similarly occur in hardening of the arteries in the neck and in the arms. So simply by doing a physical examination, you can get an idea of the overall burden of the hardening of the arteries in an individual patient. In addition, listening to the lungs can pick up things like congestion in the lungs, and I don't mean congestion like being sick, but fluid backup in the lungs because potentially the heart muscle is not working properly. Along those same lines, looking at what we call the peripheral exam, meaning into the neck and down into the legs, you can hear abnormal blood flow in the carotid arteries. Again, a sign of ongoing atherosclerosis and hardening of the arteries. As far as peripheral signs of heart function, if we see edema or swelling in the legs, that can mean that the heart pump is struggling and not working efficiently, and may be a physical sign that the heart has actually become weakened as a result of blockages in the heart arteries. From here, we move to laboratory data. If someone is having ongoing symptoms when they're being evaluated, obviously you need to make sure they're not having a heart attack at that particular time, which changes the acuity of the situation and how quickly all of this needs to be taking place. But there are specific labs that are checked to determine whether or not the heart muscle is in jeopardy, and they are twofold, one called a troponin and the other called CKMB, which is creatinine kinase. And both of these, the troponin and the creatinine kinase, are specific to heart muscle, particularly when it's fractionated to the heart muscle. There's creatinine kinase in all the muscles throughout the body, but the creatinine MB is specific for heart, and we only see that elevated if there's a problem with the heart muscle, and this can tell you that the heart is really in jeopardy at this time. Plus, other things that you want to check are obviously a basic blood count to make sure the patient's not anemic, as well as things like renal function and electrolytes and what have you. Those are basic for pretty much any physical examination workup. In addition, a hemoglobin A1C, which is a determination of glucose management in the patient. In other words, are they diabetic or not, which puts them at a higher risk for coronary vascular disease, as well as what's called an HSCRP, or C-reactive protein. And this is an indicator of overall inflammation in the body. And all of these things are just trying to help you assess overall risk factors for these patients that we already know are symptomatic, and we're probably headed down a road of really focused diagnosis for coronary disease. In addition, we then move to non-invasive testing, from labs to non-invasive testing. What does that include when we're talking about cardiac evaluation? Typically an EKG, obviously, to make sure that there's no acute or active heart attack occurring at the time, or signs of old heart attacks as well as an echocardiogram, which is simply an ultrasound. It's exactly like what pregnant women get to be able to see the baby and make sure that a fetus is growing appropriately. The same type of technology is utilized on the chest to actually look at two major things. One is whether or not the heart valves are working properly, and to look at the strength of the heart pump itself. And this is a very important factor. Why? Because patients with strong hearts have a much better chance of survival long-term than patients with weak hearts. So knowing what the patient's heart function is very, very important. Stress tests are utilized if you're uncertain of the diagnosis. There's different types of stress tests, really two that are utilized commonly. One is you're placed on a treadmill with EKG pads on. You walk at various speeds at various inclines, and the EKG is being watched by a technician. If you develop chest pain, you tell the technician, they look at the EKG and see if they can associate specific EKG changes with your symptoms. Sometimes you have symptoms with no EKG changes because the EKG is not quite sensitive enough to pick that up. But the fact that you have symptoms at a given level is very important. The next is a nuclear stress test, which is where the heart is stressed either by getting on a treadmill or exercise bike or by pharmacologic means or giving drugs while the x-ray is being taken, because that'll increase the heart rate. The dye is then put in and pictures are taken of the heart itself. And what it does is it compares perfusion or blood flow of one section of the heart to another while it's under stress. So it can say, is the front of the heart not getting as much blood as the back of the heart, or vice versa. There are limitations to all of these particular studies, but they are good screening tests for patients where there's any uncertainty. But again, the symptoms that these patients have typically push you to something called cardiac catheterization, which is the gold standard for diagnosing blockages in the heart arteries. Obviously, if someone comes in with an active heart attack, we do the lab work, a physical examination, and what have you. But basic things like chest x-ray, EKG are done very quickly, and then they're taken directly to the catheterization suite. Why? Well, of course, if there's blockages in those heart arteries that are causing a heart attack, you want to get those blockages open as quickly as you can, and the way to do that is to identify those blockages. So the way that a cardiac catheterization works is either accessing an artery in the wrist, the radial artery, or an artery in the groin, the femoral artery, with a small catheter, and then directing that catheter to the heart and then into the heart arteries. Under x-ray guidance, dye is injected into those arteries, and you actually get a full road map of the heart arteries themselves. You can immediately tell whether or not there's anything blocking the blood flow in each segment, the front, the side, and the back, as we alluded to earlier, and you can actually intervene or put stents in if it's appropriate at that time. The gold standard here is cardiac catheterization, but the workup, as you will see with each of these categories, involves history and physical examination, what's going on, are they having symptoms or not, and then directing the workup accordingly. So that is the symptomatic patient category. Now, let's move into the asymptomatic patients. In other words, you feel fine, but you hear that heart disease, particularly coronary disease, is the #1 killer worldwide, taking 19 million lives a year, and you want to know if you have that. Well, basically, the important distinction here is stratifying risk. In other words, are you at low risk for coronary disease, intermediate risk, or high risk? That then determines how the workup unfolds. So let's back into it a little bit. When do you start worrying about this? Well, the truth is you want to be risk stratified starting in your 20s and 30s. Well, what does that even mean? Well, family history, if you've had people in your family die young from blockages of the heart arteries, that's very important. Remember, we can't run from our genes, so family history is very important. Smoking, huge risk factor for heart disease. High blood pressure, huge risk factor for heart disease. Obesity, also very significant. Important to have your cholesterol levels checked very early in your 20s and 30s, so that you can begin to stratify where you fall. Many people in their 20s and 30s don't think about this at all. That's okay. The American Heart Association recommends that once you reach 40, you are risk stratified, so that you can have appropriate workup to determine whether or not you have heart disease and how to then direct therapy after that. Obviously, these patients show up and say, I feel fine, I'm just worried if I have heart disease. So the questioning really then is in the overall lifestyle that they're living, family history, their social habits, and things of that nature. Then you move to physical examination. You're going to document whether or not they have signs of heart failure. Listen to the lungs, listen to the heart. What are blood pressure in both arms? Again, looking at the periphery, the legs and the arms, looking for signs of early cardiovascular disease. In many of these patients, all of those things are going to be entirely normal, but not always, particularly in patients that get stratified into the moderate and high risk categories. From there, you're going to move to necessary labs, which again will include basic blood count and chemistries, which will include the electrolytes and kidney function, in addition to either a fasting glucose or, again, the hemoglobin A1C, which is a very sensitive way to pick up diabetes, because diabetes is, again, a significant risk factor for coronary disease, as well as looking at the C-reactive protein for overall body inflammation, and a very specific lipid panel to include HDL, LDLs, triglycerides, as well as ApoB and LP(a), which are subgroups of your cholesterol panel that again can help stratify your risk. As far as non-invasive testing to help stratify risk, again, an EKG can tell you whether or not the patient is in a normal heart rhythm at the time, if there's sign of old heart injury. Something called an ankle brachial index. Sounds complicated, but it's really not. It can actually pick up significant numbers of patients that have early hardening of the arteries. Ankle brachial index. So it measures the blood pressure at the ankle and compares it to the blood pressure in the arm. And based on that ratio, again, if there are signs of blockages in between the legs and the arms, that can lead you down a path that this patient is at least moderate, if not high risk. If patients fall into an uncertain or potentially intermediate category, then the recommendation is that these patients get a calcium scoring CT scan. Sounds complicated, but it's really very straightforward and fairly low risk. What this entails is being placed in a CT scanner, the donut, not totally closed in like an MRI. Within 2 to 3 minutes, your body is scanned very quickly, very limited to the chest, and it can actually quantify the burden of calcium in the heart arteries themselves. Now, this is really helpful for patients when it's totally normal and when it's really abnormal, because that then can take you down the road of, well, we just need general surveillance, depending on your age, every year or consequent to that as we get older. Or if it's really abnormal, even though these patients are not having any symptoms, it may push them down a road of invasive testing, again, to the gold standard of cardiac catheterization. The stress test in these patients is useful if you have a high suspicion that patients have coronary disease or they fall in the high-risk category, or something like a calcium scoring test is intermediate and you don't want to put them through an invasive test. That's a great way to determine if that calcium burden is important. Remember, the stress test compares blood flow at one section of the heart to the other sections in a relative fashion. So if there's decrease in that area of concern, then that again would push the patient to cardiac catheterization and try and delineate whether there's an important blockage or not. Now, cardiac catheterization can be the first line of testing in a certain group of patients. Obviously, if somebody is having a heart attack, there's no question they need to be taken to the cath lab, which is where this is performed, the catheterization lab, so that that blood vessel can potentially be reopened, because time equals heart muscle saved. So that is a no-brainer. Patient having a heart attack goes directly to the cath lab. Again, a patient with a really abnormal calcium scoring test, and you're concerned that it's a significant blockage, cardiac catheterization can certainly be first line. If patients are having symptoms of unstable angina, meaning they're having pain at rest but not really having a heart attack, then obviously going to the cath lab is important. If they're, again, at high risk of cardiovascular disease and you're just uncertain of the diagnosis and they're going for a high-risk operation separate from the heart and they need to be cleared for that, cardiac catheterization can help. Or if someone ends up having an echocardiogram and has signs of a weak heart muscle, determining why that heart muscle is weak can be very important. And these patients, I bring these up because they can fall both into the asymptomatic and symptomatic categories. So there is crossover between these two, but just so you understand that symptomatic patients typically end up in the cath lab if they're high suspicion. Asymptomatic patients, you want to risk stratify and then decide whether or not invasive testing is appropriate. This episode is brought to you by Sisu Saunas. Sisu makes the highest quality saunas on the market. Not only do they look amazing, but they can reach temperatures up to 230 degrees Fahrenheit. Typically, our Sisu is set at 170 to 190 degrees, and we stay in for 10 to 20 minutes depending on the day. Sisu saunas are perfect to go indoors or can weather the outdoors with a simple roof kit. They have models comfortably fitting anywhere from 2 up to 6 people. I implemented sauna sessions in my weekly exercise routine because of the growing evidence suggesting potential health benefits, such as decreased cardiovascular risk and all-cause mortality. However, results can vary, so always consult your healthcare provider before starting such a program. If you're on the hunt for a new sauna or looking to upgrade your infrared sauna, head to www.sisulifestyle.com/London and use code London to save money at checkout. That's www.sisulifestyle.com/London and code London at checkout. Let's move into the next category, which is problems with the heart valves. And again, this is a very large topic. But the three that I see most commonly are blockage of the aortic valve, leaking of the aortic valve, and leaking of the mitral valve. Remember, the aortic valve is the main valve that is in between the pumping ventricle or the left ventricle of the heart, getting fresh blood out into the aorta. The mitral valve is the valve that sits between the left atrium and the left ventricle or big pumping chamber. So interestingly, the most common problems that I see are valves on the left side of the heart. That may be due to pressure-related issues as far as just being under more stress, but there's a variety of reasons, and we won't get into the specifics of it. One of the things that I want to set up at the outset of this discussion about valvular disease is you're going to feel like there's a lot of crossover with the symptoms and how patients present as they did with coronary disease. But the difference is that with valvular problems, we're talking about a structural or architectural problem, not a blood flow problem to the heart muscle itself. So the way this is diagnosed is very different, but I don't want you to get lost in the fact that the symptoms sound exactly the same. I will point out where that delineation point is, and it's very clear, but I just want you to be aware of it at the outset. So let's start with aortic stenosis or blockage of the aortic valve? Well, many of these patients present with symptoms of fatigue early on. Again, exertional shortness of breath, much like coronary disease, can actually have chest pain if it's really severe. They can nearly pass out from the inability of the heart to get blood through a very small opening. And again, these are very similar symptoms to coronary artery disease. So how do you tell a difference? Well, here's where physical exam can really lead you down a different path. Most patients, when they have significant symptoms like this, or even when they don't many times, when you place a stethoscope on the chest, you hear a murmur. Well, what is a murmur? A murmur is just abnormal or turbulent blood flow across the valves. Think about it as like when you're turning the nozzle on a hose. When it's open very wide, it's very soft and fluid sounding, but when you turn it really tight and the blood's being shot out, it's like psh, psh. That's what it sounds like through a stethoscope when you hear many murmurs, particularly what we call an AS or aortic stenosis murmur. So this immediately raises the suspicion that this is likely not a coronary problem, although it can be combined with a coronary problem, but there's an immediate red flag that this is likely a valvular problem. Now, obviously, you want to get some basic labs again to see what the patient's overall physiology is. That will include the basic blood count, kidney function, lipid panels, because again, the hardening of the aortic valve, the risk factors are very similar as they are for coronary disease. The next step, unlike coronary disease, as far as really making this diagnosis, and again, in this case, the gold standard, is the echocardiogram that was utilized again to evaluate the valves for coronary disease and heart function. Once the suspicion is high, the echocardiogram is the confirmatory test. Now, there are two types. One just goes on the surface of the heart, as we discussed, very much like the fetal or pregnancy ultrasound. And this can give us a very good idea of heart function and valve function. Sometimes the patient's body habitus or the position of the heart in the chest can make getting images adequate. So a more invasive type of testing is called a transesophageal echocardiogram. Transesophageal just means down the esophagus or down the throat. Patients are sedated and the probe is passed actually down the swallowing tube next to the heart. So the probe gets very close to the heart, so the images are very crisp and very clear, and this can really help delineate the architecture of the valves if it's not clear on the surface echo. Once you have made the diagnosis of aortic stenosis, then of course, as patients are taken down the treatment course, which we will get to in the next episode, a cardiac catheterization is appropriate to rule in or rule out blockages in the heart arteries as well. And we'll talk more about that in a different episode. Next on the list is aortic insufficiency or a leaking aortic valve. And again, the symptoms are so similar: shortness of breath, fatigue, palpitations in this case, because this is a leaking valve. It's where the leaflets themselves or portions of the aortic valve don't come together or have been destroyed from infection or other causes, and the blood moves forward and back into the pumping chamber, and over time it becomes very swollen. Physical exam is critical here because again, you can hear that to and fro movement of the blood, and this can take you directly to echocardiogram to confirm this diagnosis. Obviously, there's other things that you're looking for here, and same with aortic stenosis, again with the physical examination where we look for things like swelling in the legs, shortness of breath to the point that patients can't lay down well easily. And these are signs that the heart is beginning to fail. And the great thing about the echo, whether it's aortic stenosis or aortic insufficiency, we get a good look at the valve, but we also get a very good look at the heart function, which again is the primary determinant of survival in each of these disease processes. The third common valve abnormality that I frequently see is leakage of the mitral valve or mitral regurgitation. Once again, we begin with a history and physical examination that typically includes things like fatigue, shortness of breath, palpitations. Sound familiar? Absolutely. From there to the physical examination, you can delineate aortic murmurs from mitral murmurs based on where you hear them best on the chest to give you an idea as to which valve is involved. In addition, again, looking for signs of heart failure, which is swelling in the lower extremities, other signs of atherosclerosis if important. Then we move on to basically the exact same laboratory values that we looked for in the other patients, which is complete blood count, renal function. In this case, also looking for some of the heart failure labs that can tell you if the heart's working efficiently. We don't need to get too far into the weeds with that, as well as a chest x-ray, because with the mitral regurgitation, early signs of pulmonary congestion or the backing up of fluid in the lungs can be a sign that things are more advanced than realized. Echocardiography is the mainstay. We can get a really good look at the mitral valve, and we can categorize the leakage as mild, moderate, or severe, which tells us if it can just simply be followed, if medical management is appropriate, or if in fact surgery is indicated. Now, the interesting thing is that many valve problems are picked up on routine examination when your physician listens to your chest. That's what they're listening for, both to the lungs and for your heart sounds. And many of these things are picked up incidentally, if you will, or patients are getting echoes for other reasons and they're picked, and valvular abnormalities are picked up. But that's a good thing. Why is it a good thing? Well, it's important that valve abnormalities are picked up early and followed or intervened on early, because it's always best to intervene or start medical management before the heart begins to fail. Because again, heart function is the determinant of mortality, whether it's medical management or whether it is taking a patient to surgery, because patients with strong heart pumps do so much better than patients with weak heart pumps. So early diagnosis, early follow-up, early intervention before the heart begins to fail is critical, particularly in valvular abnormalities. Let's move on to the third category of electrical problems with the heart. The two most common that I have come in contact with or encountered over the last 25 years are atrial fibrillation and heart block or bradycardia or slow heart rates. And we'll talk about each of these. Let's start with atrial fibrillation. Well, what is atrial fibrillation, first of all? Atrial fibrillation is a very discoordinated, inefficient heart rhythm where the top of the heart is beating like a bag of worms and the bottom ventricles of the heart are beating in a very irregular, inefficient fashion. This is a very common heart rhythm. It is not immediately dangerous as far as sudden death, but there is a significant risk of stroke with atrial fibrillation, and over time, when patients remain in atrial fibrillation, the heart will continue to work inefficiently and will eventually become weakened. So, how does the workup unfold? Again, it begins with the history and physical examination. The history is typically palpitations, irregular heartbeats, fluttering of the heart, shortness of breath when they get up, and try, when patients get up and try to exert themselves, dizziness, or occasionally even stroke or stroke-like symptoms can be the presenting symptom for atrial fibrillation, and this can really be quite devastating. On physical examination, what are you going to pick up? Well, an irregular heartbeat to begin with. Then you're going to look for, again, signs of heart failure based on the duration of how long that patient has been in atrial fibrillation. Are they in atrial fibrillation all the time, or do they say, I feel my heart fluttering sometimes and it goes away for a couple weeks and then it comes back? And then the next question is, well, what brings it on and what makes it better? So you want to know about triggers, things like alcohol, nicotine. Sleep apnea can actually incite atrial fibrillation by putting strain on the heart. Hyperthyroidism, because it's a very fast heart rate, an increase in thyroid hormone in the body can actually trigger atrial fibrillation, as can high blood pressure and leaky valves, as we were talking about before. Why leaky valves? Well, particularly mitral regurgitation, it's the valve in between the top chamber on the left and the bottom chamber. Well, when blood's going forward and backward, the heart becomes swollen and it stretches that portion of the heart and can actually trigger this very abnormal heart rhythm. The basic labs, again, are always checked: blood count, kidney function. But here, with rhythm abnormalities, electrolytes can be important, like potassium, magnesium, and calcium, as well as, again, checking the thyroid panel to make sure that there is an undiagnosed hyperthyroid. What's the gold standard to diagnosing atrial fibrillation? It's the 12-lead EKG. You have an electrical problem, you get an electrocardiogram to make the diagnosis. The trick is many of these patients are not in atrial fibrillation all the time. They come with the complaints and said, last week I had these palpitations and I felt really dizzy, but I feel okay now. How do we catch that? How do you pick that up? Well, there's two ways. One is with a Holter monitor, which is a monitor that the patient actually wears externally. And typically it's for a minimum of a week or 2 weeks or sometimes longer, depending on the individual circumstances. And then that data is downloaded and you get a 24/7 recording of the heart rates and the heart rhythms over that period of time, and you can see if they are intermittently in atrial fibrillation. In addition, there's an implantable form of monitoring. It's called a loop recorder. It actually looks like a small thumb drive, and just under local anesthesia, a small incision is made on the chest, and just in the subcutaneous tissue, or the tissue just under the skin itself, this little thumb drive is actually implanted. It's got a battery that lasts about 2 to 3 years, and it can be continuously monitored. And this is the way to pick up whether or not patients are going into or out of atrial fibrillation. It's great for monitoring patients after they've had therapy to make sure that they're staying in a normal rhythm thereafter. But that's the basic workup for atrial fibrillation. Echocardiogram can be added to this, of course, to look at heart function and valvular function. That's how you can determine if, in fact, there is a leaking heart valve. But that typically is individualized per patient as to whether or not the echocardiogram is utilized as a front line. But typically it will be if someone remains in atrial fibrillation, again, to make certain that the heart function is maintaining and not declining. The second category is heart block or bradycardia, or a slow heart rate. The symptoms here, again, starting with history and physical examination: fatigue, dizziness, exercise intolerance. Why would that happen? Well, if someone has heart block and they can't get their heart rate up, they may be fine at rest, but when they exert themselves, the body is not able to give the necessary heart rate response to keep up with the blood supply for the rest of the body, so they just can't push themselves through exertion, whether it's simple things like taking a shower, taking the trash out, or walking upstairs. In addition to feeling like they're going to pass out, or something called syncope, simply getting up out of a chair, patients can get very lightheaded if they can't mount an increase in their heart rate to compensate for the change in activity level. What are the most common reasons that this occurs and the things you need to ask in the history and physical examination? Well, medications are typically the most common. Things that we actually prescribe can slow the heart rate to a point that patients become symptomatic like this. Obviously, the treatment's pretty easy, either stopping those medications or changing them. As opposed to hyperthyroid with atrial fibrillation, hypothyroid or low thyroid levels can actually be a cause of very low heart rates. Sleep apnea, just like it can cause higher heart rates, can also cause what we refer to as bradycardic heart rates as well. On physical examination, what's the definition of heart block or bradycardia? It's heart rates less than 60 or a pulse rate less than 60 that is symptomatic. But that's not necessarily abnormal. Obviously, trained athletes many times have heart rates in the upper 30s and low 40s. They have absolutely no symptoms, and that is an adequate heart rate for them. But by definition, less than 60 is actually bradycardic. What else do you see on physical examination? Well, if patients are unable to get adequate heart rate, to mount an adequate heart rate and deliver blood adequately to the body, the extremities can become very cool, and you can pick this up on physical examination, as well as mental status, levels of alertness, and things of this nature. With acute changes in patients that had normal heart rates at one time, now very slow heart rates can have changes in their mental status. Labs, again, the basic labs, blood count, electrolytes are important, potassium, magnesium, and calcium, as well as renal function. And the thyroid panel, again, is important, but this time looking for hypothyroid. 12-lead EKG, again, electrical problem. We do an electrocardiogram. We can identify heart block. Holter monitors if the symptoms are intermittent and there is a high suspicion. Echocardiogram, again, for long-standing patients or that are resistant to therapy, or even patients that end up with pacemakers as a result of the low heart rate, because pacemakers may induce actually less than efficient heartbeat over time. Certainly not in everybody, but it can certainly occur. So an echocardiogram is very important to follow heart function. So just to recap, the diagnosis of the three main categories. First, blockages in the heart arteries, symptomatic versus asymptomatic. Symptomatic, a little bit more straightforward, typically ending up either with stress testing or an invasive test like cardiac catheterization, versus the asymptomatic patients where you start with risk stratifications. Low risk may just need yearly follow-up and appropriate labs. Higher risk patients may in fact end up with invasive testing as well. Valvular problems, symptoms can be very, very similar, or again, you can have patients that don't have any symptoms where heart murmurs are picked up on physical examination or echocardiograms for other reasons. Again, even though the symptoms are the same, we're talking about a structural abnormality within the heart where the heart valve is either blocked or it's leaking, and this is very clearly delineated with echocardiogram. Again, the echocardiogram in this case is also crucial for evaluating heart function, just as it is for blocked arteries, because strong hearts do better than weak hearts. And finally, the electrical problems. The diagnosis is split into two categories: fast heart rates and slow heart rates. The most common that we see is atrial fibrillation. And slow heart rates, the most common is heart block or symptomatic bradycardia. And this is diagnosed primarily with physical exam and EKG. But again, echocardiogram is an important component, because knowing the patient's heart function, knowing your heart function, if you have these things, is going to be the single most important determinant of how you do with a procedure, how you do with a big operation and what your overall longevity is, even if medical management is the course that you're going to take. I hope that this gives you a bit of an overview of the diagnosis of the common diseases of the heart. The next episode will then investigate the treatments in each of these areas. If you're watching this on YouTube, don't forget to like and subscribe so you don't miss future content. If you're listening on Spotify or Apple Podcast, you can leave up to a 5-star review and share this podcast with someone you think will find it valuable. I hope you guys have a great day.